Morning, everyone. So I'll be beginning with the case presentation today. Clinical history: 19-year-old primary gravida patient, a female patient who had a full-term normal vaginal delivery 15 days ago, came with the complaints of high-grade fever with chills since 10 days and numbness of bilateral upper and lower limbs. The symptoms are more predominant on left side. Later, she also complained of occasional blurring of vision with reduced hearing on left side. Past history: patient had a history of typhoid post delivery, was on medication and was referred to BIMS Belagavi for further management. Obstetric history: primary gravida, full term normal vaginal delivery, and the pregnancy was uneventful. Blood investigations showed normal liver function tests and renal function tests and serum electrolytes. Blood counts showed the mild leukocytosis with the peripheral smear showing neutrophilic leukocytosis. Patient was advised to undergo MRI scan of the brain. So here we can see DW and ADC image where it shows diffusion restriction in involving the bilateral thalamic regions, with DW showing bright signals and ADC showing corresponding dark signal. This is a T2 weighted axial image taken at the level of thalamus. So, and the flare axial image taken at the same level, showing bilateral hyperintensities in thalamic region. This is a T1 axial image taken above the level of lateral ventricles and corpus callosum. It shows a hyper intense signal in the inferior sagittal sinus, and we are coming down with the sections. So as we come down, the hyperintense signal still persists in the internal cerebral vein. Uh, the hyperintense signal in the internal cerebral veins and the inferior sagittal sinus. So while still coming down, the hyperintense signal still persists. With this is a section taken at the level of thalamic region, and it shows still the hyperintense signal here, and in the straight sinus and little bit in the transverse sinus, and sigmoid sinus also there is hyperintense signal. These are T1 weighted sagittal image showing a T1 hyperintense signal in the straight sinus and internal cerebral veins and inferior sagittal sinus. This is a susceptibility weighted imaging. It shows blooming signals in the thalamus, more predominant on right side, and it shows blooming signals in the uh, dural venous sinus, the straight sinus, which signifies there is a significant thrombosis. So, summarizing the MRI findings, there is diffusion restriction in bilateral thalamus seen on diffusion weighted imaging, and T2 flare shows abnormal hyperintensities in bilateral thalamic region, predominantly along its medial aspect. Hyperintense signals is also noted in posterior limb of right internal capsule, extending into right cerebral peduncle. Even shows hyperintense signals in bilateral internal cerebral veins, inferior sagittal sinus, straight sinus, right-sided transverse sinus, and sigmoid sinus. Susceptibility weighted imaging shows hemorrhagic blooming signals in bilateral thalami, and blooming signals are also noted in the dural venous sinus, which signifies thrombosis. So later patient was advised to undergo MR venogram to confirm the thrombosis. So this is a coronal image showing where the left-sided transverse sinus and superior sagittal sinus are patent, and the right-sided transverse sinus, sigmoid sinus is completely opacified, not visualized. This is a sagittal image showing the patent superior sagittal sinus, and the same thing, the right-sided transverse sinus and sigmoid sinus is not visualized.
It is sagittal sinus, straight sinus.
Not visualized. MR venogram findings: absent flow signals are noted in bilateral internal cerebral veins, inferior sagittal sinus, straight sinus, occipital sinus, right-sided transverse, and sigmoid sinus. The impression is the bilateral thalamic venous infarct due to dural venous sinus thrombosis. So coming to bilateral thalamic infarctions, they account for around less than 0.6% of all cerebral infarctions. Causes include artery of Percheron infarct, cerebral sinus venous thrombosis, and top of basilar syndrome. So coming to general neuroanatomy and functions of thalamus, thalamus acts as a relay center between cortex and the midbrain. Functions of thalamic nuclei include visual is taken up by medial geniculate nucleus, preliminar and lateral dorsomedial nucleus. Auditory sensation pass through lateral geniculate nuclei. Somatosensory is a function of ventral posteromedial and ventral posterolateral nuclei. Motor, ventral lateral and ventral anterior. And autonomic control and emotion and sleep wake cycles are taken up by medial dorsomedial nucleus. Thalami lie within the watershed territory in the anterior and posterior vascular territory of watershed territory. Arterial supply comes mainly predominantly from posterior cerebral artery. Anterior thalamus is supplied by thalamotuberal arteries, which is a branch of posterior communicating artery. So there is also some circulation coming from anterior circulation. Paramedian thalamus is supplied by thalamoperforatus, which is a branch of P1 segment of posterior cerebral artery. And lateral thalamus is supplied by thalamogeniculate artery, uh, medial and lateral posterior choroidal artery, which is a branch of P2 segment of posterior cerebral artery. There can be a vascular anatomical variant called artery of Percheron. Venous drainage, there are mainly two veins, thalamostriate veins and perforating veins. Thalamostriate veins drains into internal cerebral vein. Perforating veins drains into basal vein, which then drains into great cerebral vein of Galen. Both internal cerebral vein and basal vein, they join and drain into internal cerebral vein of Galen, which then drains into the straight veins.
Yeah, another small vein
The basal vein.
septal vein with thalamostriate forms internal sinus. With your inferior sagittal sinus forms the vein of Galen, and then before that and final forms the straight sinus.
So this is a pictorial representation of the arterial and venous supply. From the posterior cerebral artery, the P2 segment starts after the posterior communicating artery. So thalamogeniculate artery and posterior choroidal and posterior medial choroidal artery supplying the lateral thalamus. The polar artery or the thalamo tuberal artery supplying the anterior thalamus, which originates from the posterior communicating artery, and the paramedian artery taking origin from the P1 segment supplies the paramedian thalamus. This is the venous drainage, mainly from thalamostriate veins draining into internal cerebral vein and basal vein of Rosenthal draining into the both of them combined draining into the great cerebral vein of Galen. Risk factors for thalamic infarctions include atherosclerosis, atrial fibrillation, ventricular wall aneurysm, left to right shunts, hypercoagulable states, hypertension, diabetes mellitus, hypercholesterolemia, and smoking. All of these lead to generation of thrombus, which can later cause infarction. Coming to dural sinus thrombosis as a cause, occlusion of internal cerebral veins and straight sinus. There is increased internal intracranial pressure due to the defective drainage of the venous drainage, so that causes back pressure and hampers the circulation, which causes headache and can lead to papilledema. Risk factors include pregnancy, as was in our case. OCP uses, like it's more common in females, sinusitis and mastoiditis. Idiopathic cause is present in 25% of the cases. MRI findings in dural sinus thrombosis leading to thalamic infarct show bilateral thalamic hyperintensities on T2 and flare. T1 shows hypointense signal in thalamus and hyperintense signal in the affected thrombosinus. MR venogram shows filling defect. So this is the dural sinus venous anatomy showing superior sagittal sinus and the inferior sagittal sinus with the straight sinus here and this forms in the venous confluence and transverse sinus, and then continuing as sigmoid sinus bilaterally. CT findings in non-contrast NCCT findings include hyperdense sinuses and hypodense area of infarcts. CCT will show enhancement around the thrombus within sinus. That's called empty delta sign. So in this picture, there is thrombosis of internal cerebral veins, which appears bright, and it appears as if there is some contrast enhanced image. So this is the internal cerebral veins thrombus, and the great cerebral vein of Galen thrombosis, the straight sinus thrombosis. The sagittal image of NCCT shows the thrombosis of inferior sagittal sinus with the straight sinus. The pathology is uncommon in 15%. Usually, both the internal cerebral veins and vein of Galen with sagittal sinus is involved. Imaging, as I've described, hyperdense internal cerebral veins may look like a seed CT scan. Bithalamic edema is common. Variable hemorrhages can occur due to back pressure. CT venogram shows non-opacification of deep veins, and digital subtraction angiography shows absent visualization of the affected veins. Artery of Percheron, in fact, as a second cause. It's also called paramedian thalamic syndrome. Posterior circulation, it's mainly a cause of posterior circulation infarction. Symptoms include bilateral paramedian thalamus. There's a classic triad of altered mental status, vertical gaze palsy, memory impairment. Rostral midbrain symptoms due to its lesions also cause oculomotor disturbance, hemiplegia, cerebellar ataxia, and movement disorders. So this is a picture showing variants in the artery of Percheron, where the the arteries take origin from the P1 segment of posterior cerebral artery after splitting from the basilar artery. So here both the sides have individual supply. Type A shows individual supply. In type B, from both the thalamic areas are supplied by single artery taking origin from only one side. It's called artery of Percheron type B. And in type C, uh, both the areas are supplied by uh, arteries which join to form a arcuate like a confluence, and then they enter which takes origin from the P1 segment of PCA and then form the arcuate like artery. MRI finding, uh, there will be diffusion restriction seen in DWI, and T2 and flare hyperintense signals in thalamus. T1 will show hypointense signal in thalamus, and MR angiography shows is confirmatory, showing single branching vessel from P1. Here we can see the branching vessel is taking origin from only one side, and the other side it's not taking origin. And this is a T1 weighted image showing hypointensities in thalamus, and this is the axial flare image showing hyperintensities in thalamic regions bilateral. One more sign can be illustrated. It's called the midbrain V sign. Uh, there will be hyperintense signals in the due to affection due to a thrombosis of artery of Percheron. So the infarction will appear as hyperintense signals in the midbrain region, in the paramedian thalamus and midbrain region. So that can give a midbrain V sign. Coming to top of basilar syndrome, it's a thromboembolic occlusion of the superior part of the top of basilar artery, causing bilateral thalamic infarcts due to occlusion of perforator vessels, which supplies the paramedian thalamus. Clinically, you can see visual and oculomotor deficits. Behavioral abnormalities can be seen. Increased sleepiness and hallucinations can also be present. CT will show hyperdense basilar artery. CT angiography and MR angiography may show filling defect. The basilar artery at the superior part, there'll be filling defect seen. This is the MR angiography picture, and the axial sections of diffusion weighted imaging shows diffusion restriction in bilateral thalamic regions and the um, midbrain areas. The top of basilar artery infarction showing hyperdensities. So summarizing the main three causes of bilateral thalamic infarctions. MRI, all of them will show hypointense signals in the area of infarcts in T1 weighted imaging, and T2 and flare, all of them will show hyperintense signals in bilateral thalamic regions, and all the three will show diffusion restriction in the thalamic regions in diffusion weighted imaging. That we can differentiate it using MR angiography and MR venogram for confirmation. In artery of Percheron occlusion, there will be filling defect in the P1 segment of MR angiography, where artery of Percheron can be confirmed. In top of basilar syndrome, filling defect on MR angiography is seen in the distal basilar artery, and deep cerebral venous thrombosis. In MR venography, we can confirm the filling defect.